The author does not have any financial interest in this video. One of the most crucial steps in deep anterior lamellar keratoplasty is achieving big bubble by intrastromal air injection. Air injection in the deep stroma may either lead to separation of stroma from the underlying predesmate layer, which is termed as type 1 bubble. This bubble starts in the center and moves in the periphery. But sometimes the air may enter a plane where it separates the predesmate layer from the desmate layer, leading to formation of type 2 bubble. This bubble usually starts from the periphery and moves towards the center. As in this case of macular corneal dystrophy, air injection led to formation of type 2 bubble, which we can see proceeding from periphery to center. On stromal dissection, mere injection of visco between the stroma and the bare desmate to separate the stromal lamella led to rupture of the desmate membrane because of its fragile nature. Now, this was a case of 45-year-old female with best corrected visual acuity of counting finger at 2 meters in left eye, diagnosed with left eye nebular macular corneal opacity, status post healed fungal ulcer. The opacity measured 6 by 5 mm and was involving the visual axis. DALK was planned in this case. Centration is marked using the dialer. Caliper is used to determine the size of trephination. Partial trephination up to a depth of 80% is achieved using a vacuum trephine of 7.5 mm size. Bleeding is noted from the deeper vessels. Crescent knife is used to partially debulk the stroma. Air injection in deep stroma is done using 30 gauge needle attached to 2 cc syringe with its bevel down. One can see the formation of type 2 bubble starting in the periphery and moving towards the center. Keeping in mind the previous experience, we try to deflate the type 2 bubble using 15-degree knife. A second attempt is made to achieve the desired type 1 bubble. But this attempt again leads to formation of type 2 bubble. The air from the type 2 bubble is burped out from the side port. Now it is decided to proceed with the manual dissection using crescent knife. A blunt dissector is used to delaminate the stromal lamella. Vanna scissor is used to dissect out the stromal lamella. Blunt dissector is grooved under the stroma to achieve the stromal dissection and reach the predesmate layer. The procedure is repeated again and again to dissect out the stromal lamella and perform manual dissection of stroma. A non-tooth forceps is then used to peel the stroma from the underlying pre-descimate layer. Stromal dissection is achieved till the level of pre-descimate layer. A graft of size 7.75 mm whose descimate is stripped off is prepared and is placed over the host bed. The graft is then sutured to the host cornea using 10-0 nylon. Four interrupted cardinal sutures are placed, followed by placement of rest of the 12 sutures at equidistance. On post-op day 1, there was a stromal edema in the inferonasal quadrant of cornea, which was a result of DM detachment, which can be noted on AIOC and happened in the area due to formation of type 2 bubble. 1 week later, the DM detachment has resolved on its own, with cornea becoming compact and clear. The patient's vision also improved to 20/80. Proceeding with the 4-quadrant stromal dissection when type 2 bubble is achieved is risky, especially with beginners. Deflating the type 2 bubble and proceeding with the manual dissection is a good viable option for beginner surgeons to prevent inadvertent rupture of bare descimate and thus conversion of DALK to penetrating keratoplasty. Thus, it is important to modify the technique of DALK on the type of bubble we achieve. One must always try to save the host descimate for early visual rehabilitation and the immune privileges the patient achieves with DALK rather than converting it into penetrating keratoplasty.